Immediately sequential bilateral cataract surgery, yes or no? Welcome to the third EyeSee controversy in ophthalmology.
Hello, my name is Jorge Alio. I'm professor and chairman of ophthalmology, University Miguel Hernández, and founder of Vision Miranza in Alicante and other cities of Spain.
Hi there, my name is Arthur Cummings. I'm a consultant ophthalmologist at the Wellington Eye Clinic in Dublin, Ireland, and I specialize predominantly in cataract and refractive surgery. I spend 90% of my time doing that.
Let's start with the first question. Are you in favor of immediately sequential bilateral cataract surgery?
I am in favor of bilateral simultaneous cataract surgery, of course. It is an advantage for my patients. It is an advantage for ourselves as well. It doesn't involve extra risk in spite of what has been said. And I have been using this technique as an approach to my patients in some selected conditions since my residency time. It's not recent. It's about 35 years that I'm using simultaneous bilateral cataract surgery. I did it in the transition to phacoemulsification, during phacoemulsification in the era of modern intraocular lenses, especially premium lenses, and I am extremely satisfied. My patients are as well, and I truly believe it's an advantage for everybody.
No, I'm not. But in fairness, I was asked to defend this position.
What are the potential advantages?
The potential advantages of bilateral simultaneous cataract surgery are, in my opinion, demonstrated by the evidence. It's not an opinion, it's medical evidence which is behind. We have, at this very moment, very low risk in cataract surgery when properly performed by a properly trained surgeon. And these are the two elements involved in the issue: properly performed and experienced doctor. It is not for beginners, it's not for patients that have any extra risk, it's not for patients that have comorbidities, it's just for normal patients that have cataract surgery. And to undertake bilateral simultaneous cataract surgery has extra advantages when using premium lenses, particularly multifocal lenses. When implanted bilaterally, they speed up the neuroadaptation process, and it's a huge advantage for the practice of modern cataract surgery with premium multifocal lenses on its own lenses. So this is a great body of evidence that support that there is no extra risk, that there are many extra advantages, and in today's environment in which cost effectiveness is an issue, is cost effective.
So it's certainly more convenient for the patient, it's more convenient for the surgeon. There's less costs because you're only going into surgery one time. And if you think of other patient benefits, the likes of not having two eyes that are different for a week or two between the two cases, you reduce the risk of falls and so forth. Another thing we need to remember is many patients are brought in by family members who are working, so it's less time away from work. It's easier to do drops. So there are a lot of advantages.
What are the risks and drawbacks?
Okay, there are three risks that have been traditionally mentioned against bilateral simultaneous cataract surgery. The first is the eventual event of a bilateral infection. This is indeed a risk, and we know that ophthalmitis unfortunately happens still today, in spite of any opinion and any measure that has been taken. But it's true as well that bilateral simultaneous cataract surgery involves independent risk for each eye of suffering an infection, because we use totally different instruments. We change gloves, we change everything that is going to touch the patient, and the risk of each one of the eyes in bilateral simultaneous cataract surgery, which involves the change of everything like in a new surgery, is the same like having the patient in two different situations. This is the main one, infection. And bilateral infection, I have to acknowledge that have never, and I repeat, never been reported in modern cataract surgery, and those that have been reported have happened in the third world surgery or in environments in which cataract surgery is performed on suboptimal levels. The second risk is to have comorbidities. Comorbidities in cataract surgery, the main one, because it's frequent, is the event of macular edema. Pseudophakic macular edema happens eventually in up to 2% of the patients, and this is a risk that is completely true, can't happen bilaterally. But if we avoid these cases in which we have extra risk, like patients with previous diabetes or diabetic retinopathy, we avoid patients that have been in the use of inflammatory potential medication. If we have the patients excluded, like patients with previous even that old uveitis, patients that have had other type of surgeries, and patients that are exposed to complications, the risk of having this problem is controllable, and we have to remember that 98% of the pseudophakic macular edema cases disappear with time. And the third element that has been defended in favor of not performing bilateral simultaneous cataract surgery is the precision in intraocular lens calculation. That was true in the past, but at this very moment, the capability that we have to make an accurate biometry, an accurate calculation of intraocular lenses have improved that much that I have to think twice in order to remember any case in which I was not plus minus 0.5 within the refraction that I planned to have. If we have regular cases, not cases with previous corneal refractive surgery, if we don't involve patients with abnormal corneas, the risk of having a refractive surprise bilateral is minimal. And so this is why these three theoretical problems are on practical levels today in 2022. It's very certainly happening and are not constituting a risk for cataract surgery performed simultaneously or bilateral.
Right. The main risk is the risk of a bilateral endophthalmitis or TAS. And the risk is low, and it can be made even lower with intelligent planning, like using surgical packs that are designed for bilateral procedures. So the right eye has a different supply chain to the left eye. So you can really reduce the risk an awful lot. The issue is the risk is very low, but the implication of the risk being realized, that is a potential blinding effect or significant visual loss, will be very, very difficult for both the patient and the surgeon to accept, especially when the alternative, that is different day surgeries by 1 day maybe, is not that much of an inconvenience.
There has been a growing body of literature on ISBCS in the last decade. What do the studies show?
Well, the studies that have been performed has been retrospective and prospective. Obviously, grade 1 evidence is that the corresponds that to prospective randomized studies, and these randomized studies have been published with very clear results. Bilateral simultaneous cataract surgery is safe, is effective, and is cost-effective. It's safe because it doesn't involve extra risk for the patients. It is effective because, on real terms, you give a solution to the problem of the patient on only one time, and with high patient satisfaction, avoiding the problems that many people, especially the elderly, have for follow-ups. And finally, the surgeon has a much more efficient operating room activity. And finally, it's cost-effective in the environment in which we move today, in which everything has to be reconsidered in terms of extra expense. Bilateral simultaneous cataract surgery reduces the expenses, and being cost-effective because it doesn't have more complications is something that is a unique way to promote a better practice in the benefit of our patients.
The studies show that bilateral surgery is safe when practiced according to the guidelines, and the incidence of bilateral endophthalmitis is incredibly low. Dr. Steve Arshinoff has been practicing simultaneous bilateral surgery for close to 30 years now, and has had one case of endophthalmitis in all that time, and this patient did really well. And if I recall correctly, I think the infection was unilateral.
Should the patient be involved in the choice?
The patients should be involved in the choice always, because some patients are reluctant to have bilateral simultaneous cataract surgery. It is not a common practice in many practices, and so it can look to be bizarre, unusual for some patients. The patient should be informed by the surgeon that a bilateral simultaneous surgery is advisable in his or her case, because there is no extra risk. They are standard cases. They can benefit from less visits in the post-op without having an extra risk. And finally, if they are to be implanted with multifocal lenses or premium lenses of any type, that they will have a better neuroadaptation in the benefit of the final outcome. So indeed, yes, the patient should be involved, and a specific informed consent should be written, including everything about the risks and benefits of a bilateral simultaneous cataract surgery, and having a reference that the patient can take in order to understand better which is the evidence in favor that has been raised for this technique.
100% for certain the patient should be involved in the choice. They need to understand the risk. Additionally, they need to understand the relevance of the risk. Saying it is 1 in 100,000 or whatever number you are quoting is not enough. It needs to be added that if both eyes become infected, for example, that blindness may follow. So with a unilateral procedure, the risk is limited to the eye being operated. No matter how safe bilateral simultaneous surgery becomes, actuaries will continue to have one eye treated at a time as a risk mitigation strategy. They even do this with LASIK in my practice. So I have so much fun with actuaries in the practice. I would ask them after the surgery is completed at the 6-week visit. So you opted to have the two eyes treated separately. You've seen it's gone perfectly well. Now that you know it's gone this well, would you not just have done both eyes the same day? And they always come back and say no. And when I say, why wouldn't you? And they say, I want to mitigate risk. So certainly doing one eye at a time in a patient's mind is mitigating risk.
Are reimbursement issues involved in your choice? What are the reimbursement policies in your country?
In Spain, we have had traditionally freedom to practice bilateral simultaneous cataract surgery. Only if public institutions have some limitations, but even the public institutions give freedom to the surgeon to decide in the benefit of the patient. So in Spain, we have a traditional bilateral simultaneous cataract surgery since many years. In my case, of 35 years. But other surgeons in Spain have the same experience, and even that it is a personal attitude for some of them to be much more favored in bilateral or in unilateral. In my case, and if I am traditionally practicing this technique without any complications, let me tell you, in the many thousands of cataracts I have been operated along my professional life, it is something that is generalized. That means that any surgeon have the evidence that this is working. The surgeons have the evidence that complications are avoided with certain rules, and these certain rules are well written by guidelines that have been exposed by the Spanish Society of Ophthalmology. These guidelines include the two different sets of instruments should be used in either eye, that the surgeon and the assistant should change gloves between one eye and the other eye, that each eye should be draped independently in order to avoid any bilateral risk to be coming from any source of contamination. And finally, if you have a problem in the first eye, obviously you are not going to undertake any risk in the second eye. You follow these guidelines and you have the approval of your patient, you have guaranteed that your practice will be successful and the patient will benefit from something that is indeed an advantage for them. We have to think in elderly people with different difficulties for mobility that are not easy to get access to the doctor. Especially public hospitals are very crowded, and this is a huge simplification. Again, cost-effective for the practice of cataract surgery for many patients that have no extra risk, and you can find an important advantage in the practice of this approach to cataract surgery.
The second eye is charged at 50% for cataract surgery. So the first eye, a full fee, the second eye, a 50% fee. But this is not the case for custom lens replacement, which today is at least half of my IOL surgery. So with custom lens replacement or refractive lens exchange, where patients are paying out of pocket, this is not the case.
Has the COVID pandemic encouraged the practice and acceptance on ISBCS in your country and in general?
Yes, absolutely. The COVID pandemic has encouraged bilateral simultaneous cataract surgery. The reasons were clear. We had a limited access to the operating room. We had more patients to operate, and to have one eye today and the second eye in 1 week, 2 weeks, or 1 month was going to be impossible, because the operating rooms were not only crowded but could be not even useful to be accessible, because during the COVID pandemic many times the operating rooms were just reserved for emergencies that are very rare in ophthalmology. So the reason of the expansion of bilateral cataract surgery during the pandemic was clearly the lack of availability of cataract surgery and the need to optimize our resources. In this time of the pandemic, we learned about how to make much more hygienic use of all the transit of the patients in the hospitals. The patients were much better in terms of medical education about hygienic measures, And all this has encouraged and has promoted and helped a lot the expansion of bilateral simultaneous cataract surgery. Many surgeons that were not practicing this approach to cataract surgery before could have the evidence, because the need and the obligation and the pressure that we have from the society to practice this surgery bilateral, that did work and was not working against the risk of the patient. So definitely, yes, COVID has made a turning point for many surgeons and many institutions that have been forced to embrace bilateral simultaneous cataract surgery as a way to get right from many cataract surgeries that could be impossible to operate otherwise.
So I'll start off with, in general, certainly in the UK and other parts of Europe, it's become a lot more commonplace. Even in the NHS in the UK, which is a public service, as you know, up to 30% of cases in certain hospitals are being done bilaterally. So there's wide acceptance. In Ireland, that has not been the case. It's not common practice at all yet. And I'd really like to be doing it myself, but I'm full-time private practice. And I think before I start doing this on a routine basis for the right patient, I think we need to be in a situation where there are more people doing it too. So I think anytime that it's been accepted and we've reached the tipping point, it's no problem doing it. But I think if you're the only one doing it, you've got to be thinking very carefully about doing that.
Do you personally perform ISBCS? And if you do you perform it routinely or in selected patients? What protocols or guidelines do you follow?
Yes, I practice bilateral simultaneous cataract surgery since a long time. I mentioned formally 35 years. And the reasons have been, number one, my mentors, the doctors that were my masters in the beginning of my residency time, really were practicing already bilateral cataract surgery, and they were in the intracapsular era, which was much worse than it is today. So for me, that I am an extracapsular surgeon time, definitely was something that already was in my culture. So for me, it was something new. There was not something new, it was something natural. The improvement in the quality of cataract surgery, the improvement in the incisions, because the incisions were smaller, the improvement in phaco technology to reducing the risk of corneal damage and comorbidities and problems that happen during the surgery, with a tremendous decrease in the risk of endophthalmitis and tremendous decrease in complications, made us to be completely feeling safe to advise our patients to perform cataract surgery. So I do practice routinely bilateral simultaneous cataract surgery, not in 100% of my patients, but probably in about 40%. The condition for me are both eyes are in the indication, medical indication of cataract surgery. The patients are with no comorbidities. The patients have no extra risk. For instance, they don't live alone, or they don't have blepharitis, or they don't have ocular surface disorder. The patients are understanding well what is the post-op of cataract surgery. And finally, that I really think that I can help this patient with a bilateral simultaneous cataract surgery. Under these conditions, I always indicate cataract surgery. Over these conditions, I indicate always in refractive lensectomy. Refractive lensectomy is performed by me in mice over the age of 55, not early because there is already a detachment, and in helpers that are older than 50 years of age. In these patients, I do bilateral simultaneous cataract surgery because refractive surgery is bilaterally performed. LASIK is bilaterally performed. Refractive lens exchange should be bilaterally performed in order to optimize the refractive outcome and especially the neuroadaptation of the patients if you are using multifocal lenses, as I mentioned before. So in this environment in which I care for the safety of my patients, I see that no comorbidities are happening. I do follow the rules about using independent instruments, independent drapes, and changing gloves between one eye and the other, bilateral simultaneous cataract surgery, and indeed having an accurate biometry, an accurate IOL calculation. I feel very safe, and I strongly advise my patients to go for bilateral simultaneous cataract surgery. My limitations are the patients who are unwilling to do that because they have reservations about entering in the operating room for both eyes, or they really think that this is inadequate for them because their culture is not in favor of that. That includes many foreign patients that in their countries is something that they don't perform, while in the Spanish patients certainly have any problem in accepting this indication, which is indeed saving money for the patient, saving money for the institution, and finally better for the institution, for the doctor, and for the patients.
Yes, I do, especially in dementia, mental retardation, any case that's getting a general anesthesia that has a specific risk. And we do this to reduce the risk of anesthetic exposure. If the anesthetist says, I'd rather give one anesthetic rather than two a week apart, we would do this. Now, there was a society called the ISBCS Society, which was all about bilateral simultaneous surgery. And they've in fact, very recently, in the last couple of months, they've disbanded due to the fact that they no longer see their relevance. According to them, the risks have been so well mitigated that they are no longer required as a society. And again, according to them, the tipping point has been reached, and I think they may be right.
What message would you like to deliver to your counterpart and to fellow cataract surgeons in general?
I think that consider bilateral simultaneous surgery as a regular practice today. We are in a modern environment in cataract surgery and refractive lens exchange. This environment involves a much better training of the surgeons. Surgeons needs to be expert in cataract surgery, and definitely today the opportunities to learn are much better than before. You need to practice cataract surgery on a regular basis. Your rate of complications should be low. What is low? You should have a PC disruption in less than 2% of the cases to really be an acknowledged a competent cataract surgeon in the modern standards. And finally, you have to select your patient on those that are going to be in the benefit of bilateral simultaneous cataract surgery, saving time, saving visits, improving quality of life, and especially considering that modern intraocular lenses, multifocal lenses, are much better in terms of outcome if you perform bilateral simultaneous cataract surgery. So definitely, yes, consider that these indications have to be followed. Learn about the general rules to practice bilateral simultaneous cataract surgery. We recently published one paper about this, and you can read papers from other authors in which these guidelines are clearly explained as the method to perform a safe and consistent and efficient bilateral simultaneous cataract surgery. And once that you understand all this process in which your experience warrants the outcome, in which you know the rules, in which you know in which way to prevent problems, in which way you have to train your patients about this and you select your patients, just move to bilateral simultaneous cataract surgery. This will promote your success. This will promote the success of your patients, and finally will be the success of your institutions.
Well, first of all, it's very difficult to argue against Professor Alio. And besides, I like him a lot, so prefer not to argue with him. My message would simply be this: doing the two eyes one day apart mitigates much of the risk of traditional sequential surgery that would be weeks to months apart, namely time out from work, anisometropia, the risk of falling, inconvenience of two different sets of eye drops at different dosages. And it may be a very good way to prepare oneself mentally and logistically to eventually progress to both eyes same day. So if you're starting two eyes one day apart, you're not very far off from doing it at the same time, really. The main reason that I'm not doing both eyes routinely at the same setting right now is that I would be the only ophthalmologist in the country doing that. If anything were to go wrong with the surgery and I found myself in the courts trying to defend the decision, I would not enjoy much support from the local experts who would be called upon for their expertise. I think the moment that a few leading ophthalmologists around the country are doing it, the pendulum will swing to it becoming more routine for most ophthalmic surgeons.